Hi everyone, my name is Brent Sherwin, one of the third year residents going into fourth year. Just wanted to welcome everyone to the program. Look forward to meeting each one of you. Podcast I'm presenting to you is on hypotension and tachycardia. My outline for this talk is to give an example scenario, and we'll go through some differential diagnoses for tachycardia and hypotension. We'll go through the kind of checklist that I've formulated and use on a regular basis when thinking through patient issues, and then going over some tips and tricks at the end of the lecture, just to kind of recap what we have learned. For my example scenario, you were called by the nurse in the middle of the night. The patient is a 57-year-old male with a past medical history of diabetes mellitus, hypertension, hyperlipidemia, who presented originally with acute perforated diverticulitis with pneumoperitoneum. He was taken to the OR and underwent a Hartmann's procedure around 1700 hours. You are now the intern on that night and get a call around 2300 hours by the RN. The patient has a blood pressure of 70/40 and a heart rate of 125. Your senior on call with you is in the operating room working on a ruptured AAA. What are you going to do? Now, I realize this isn't necessarily a scenario I'll be faced with all the time, but I think it gives you a little taste of some of the calls you might have as an intern and some of the things you'll be presented with as far as patient care. And at first it's intimidating to figure out what to do, but I'm hoping at the end of this lecture you can systematically go through several steps to help you kind of come to a good conclusion of what steps need to be taken to deal with a patient with tachycardia and hypotension, or one or the other. For differential diagnosis, I realize this is not a comprehensive list, but I think some of the most important points on this slide are acute blood loss anemia, hypovolemia and shock, along with sepsis, infection, and pain, extremely common for our patients postoperatively and even preoperatively. We also have several patients that have an extensive cardiac history, and when they become fluid overloaded postoperatively, will convert to atrial fibrillation or atrial flutter. We also have numerous patients that have electrolyte imbalances pre and postoperatively. Think about a lot of our patients have nasogastric tubes in, which causes them to be hypokalemic. Many patients are NPL, they're not getting the nutrition they normally get, and thus they will have electrolyte imbalances. Many of our patients are anxious, which is a big component. Several patients have drug and alcohol withdrawal, and the all-important medications. Some of our patients are on medication lists a mile long, and thus it's important to look at those and make sure that some of what's happening isn't being caused by their medications or lack of taking them. I like to kind of think of patient issues in the checklist format. I feel that this helps me to not miss little details. And although this seems like a large checklist, rest assured I'm not going through every single detail that you would normally go through with a normal history and physical, but this just helps in your mind hit the high points so that you're not missing anything. I like to think of it in an HPI format and thus go through, in my mind, past medical, surgical, social, meds, vitals, intake and output, physical exam, what labs, imaging do I need, and what is my ultimate assessment and plan going to be. I'd like to run through each of these briefly. So for history of present illness, what pertinent past medical history does your patient have? Does the patient have a history of atrial fibrillation, for example? Puts them at a higher risk of getting it postoperatively if they've been controlled before. What pertinent past surgical history does the patient have? Have they had recent surgeries? Are they a fresh postoperative patient? What type of social history does the patient have? Do they have a history of alcohol abuse or drug abuse? And finally, what medications does the patient take? Are they off their normal anticoagulant that they take for their heart stents? Have they had their beta blocker held? All important things to think about when you're faced with the scenario of a patient with hypotension and tachycardia. Looking at the patient's vital signs is extremely important. A lot of times the nurses will call and give you one vital sign. For example, blood pressure of 70/40. Remember, you need to ask about the other vitals. The temperature is important, the heart rate, the respiratory rate, the O2 set. Remember, we're not just treating a number, we're treating a whole patient. And thus it's important to take all of these into account. A really important point is to always ask the nurse if they call you with a low blood pressure, have you taken a manual blood pressure? Remember, cuff size can alter the blood pressure by 10 to 20 millimeters of mercury, and also sometimes the electronic cuffs aren't as accurate, especially on our obese patients where the cuff a lot of times is too small. Another important thing to think about is how long have the vitals been like this? How long has the patient been hypotensive? How long have they been tachycardic? More important than one vital set is the trend. If the patient is on telemetry, it's nice to be able to look at the strip just to see, does the patient look like they have an irregular rhythm, or if they are tachycardic, what's the range and what's the trend? Intake and output is exceedingly important to look at for patients who are hypertensive and tachycardic or one or the other. Remember, most of our patients postoperatively will be NPO. If they're not, what diet are they on and how much are they taking in? How much IV fluids are they getting? What is their urine output? If they have drains in place, how much is coming out of them? Figuring out this balance can sometimes help you figure out what's going on with a hypertensive and tachycardic patient. Physical exam. I think one of the most important points I can make during this lecture is, as an intern, the most important thing you can do after getting a call like this from a nurse is go see the patient. This is how you learn how to deal with these patient problems, and it helps you to learn how to assess patients with these type of issues. When you go see them, check the following. Generally, how does the patient look? Do they look sick? Are they sweating? Are they pale? Are they nauseous? Vomiting? Is their pain out of control? Sometimes these are good clues of maybe what is causing the patient's problem. Look at their head, ears, eyes, nose, and throat. Their mucous membranes look dry. Is an NG in place? And if it is, what kind of output is coming out? Check their heart, check their lungs, check their abdomen/incisions. Check their ankles for any swelling. Do they have any pain in their calves? Remember, DVTs can lead to PE, which can cause tachycardia and hypotension. So important to check. For most patients that are hypertensive and tachycardic, you always want to get a repeat set of vitals. After you go see the patient, if you feel that they need some labs, these are some of the basic ones to order. Complete blood count to ensure they're not bleeding. Basic metabolic panel to see what their electrolytes are looking like. Magnesium and phosphorus, because the basic metabolic panel doesn't have those. And arterial blood gas, I would especially recommend if the patient is hypoxic or the respiratory rate is significantly increased. As far as imaging for patients that are hypertensive and tachycardic, chest x-ray can tell you sometimes, for example, if you're worried about a perforated viscus, is there free air under the diaphragm? It can also show you if there's a pneumonia brewing or pleural effusions, causing the patient to be tachycardic or having increased respiratory rate. KUB is also somewhat helpful to check gas pattern, see if maybe the patient is becoming if they have an ileus or a bowel obstruction, or to check the NG tube placement. EKG is helpful for patients that are tachycardic to see what kind of rhythm they have and whether they have any abnormalities. Finally, assessment and plan. I feel I'm speaking on behalf of all my colleagues. As a senior, we would much rather know about these patients earlier on. Thus, if you get the call, it is very helpful to call your senior or text them right away and say, hey, I'm seeing this patient up on the floor. They have this type of issue, hypotensive, tachycardic, or both. And then your senior has time to go look at the patient's chart. And if something looks funny early on, they can come help you with assessing the patient. After you've assessed the patient, I would recommend taking 1 to 2 minutes to think through your differential, what you feel should be done, and what kind of plan you want to do to help alleviate or change the problem. Then give your senior a call and say, hey, Mr. or Mrs. So-and-so is hypotensive and they're having some tachycardia. I think they might have acute blood loss anemia. I'm going to check some labs, check some imaging, and depending on what these show, patient may or may not need blood. That type of thing is very helpful in you developing good thinking skills as you become more senior throughout your time in residency. Finally, some tips and tricks. If the patient is bleeding, give them blood. Don't give them volume. All you're doing is diluting out their RBCs. If the patient's volume behind, give them volume. Start with crystalloid first. I usually start with a 1 liter bolus of the appropriate normal saline or lactated ringers. If this doesn't have any response and that the patient's urine output doesn't pick up, or their hypotension doesn't resolve, or tachycardia doesn't resolve, you can try some albumin. Beyond this, you might need vasopressor support, but the patient really needs to be in the ICU to receive this, and your senior should definitely be involved at this point. Remember to have a low threshold to transfer patients to the ICU if you're concerned about them. You'll never be faulted for being aggressive about taking care of a patient. You will be faulted for thinking the patient maybe just has some anxiety and when they really are having a real problem. And always assume the worst things first. Rule out the things that can kill the patient first, then deal with the more minor things or the zebras that maybe aren't as common. Remember, common things are common. If someone has hypotension and tachycardia postoperatively, just assume they are bleeding or volume behind until proven otherwise. Finally, some parting words of wisdom. Remember, always call your senior. We're always happy to help. Always go see the patient and always assume the worst. I think if you can keep these principles in your mind as you start your intern year, you may not know all the answers, and you won't when you first start. But if you carefully consider these points, I think you will develop good habits and skills that will help you as you become more senior during your residency. Thanks for listening, guys. And once again, welcome to the program. We'll see you around.